Let me tell you about Sarah. She was a 62-year-old woman who had a stroke a few months before she came to our clinic. On the surface, she was doing okay. She could walk without a cane, which she was incredibly proud of. But she felt off. She described this persistent feeling of instability, a fear that she might topple over with the slightest misstep. Her family doctor had cleared her for most activities, but Sarah's confidence was shattered. She avoided going out, turned down invitations to walk with friends, and her world started to shrink. It was a classic case where the basic ability to walk was there, but the quality and safety of that walk were compromised, impacting her entire life. We could have given standard strengthening, but that wouldn't address the root of her fear. Instead, we decided to dig deeper. We simply asked her to walk while we watched, just a trained eye and a phone. What we saw was subtle but significant. Her steps were asymmetrical. Her left leg, the one affected by the stroke, had a much shorter stance time. She rushed to get off it, almost like walking on hot coals. Her trunk slightly lurched to the right to compensate, a tiny shift to maintain balance. This simple observation, basic gait analysis, changed her plan. The problem wasn't just weak muscles, it was a motor control and timing issue rooted in her brain's recovery. She didn't trust her affected leg, so her nervous system built a safe but inefficient workaround. This pattern drained energy and reinforced fear. Inefficiency made every step more costly. Armed with this understanding, we shifted from generic strengthening to targeted interventions. We encouraged more time on her left leg in a safe, controlled environment. We used light tactile cues, like a tap on her hip, to guide alignment. A metronome helped her internalize a more symmetrical rhythm. Slowly, her brain remapped and trust returned. Her steps became more even, her confidence grew, and soon she was back to walking in the park with friends. It all started not with a fancy machine but with watching her walk. In Neuro Rehab, gait is more than traveling from point A to point B. It's a window into the central nervous system. Think about it. Walking is complex, rhythmic, and automated. Sensory systems, brain, and muscles in constant conversation. Neurologic conditions disrupt that conversation. Stroke, Parkinson's disease, multiple sclerosis. Gait analysis lets us listen in and pinpoint where communication breaks down. We transform a generic diagnosis into a personalized, functional problem list. Abnormal gait is a barrier to independence and quality of life. It raises fall risk, drains energy, and limits social, professional, and family participation, and fuels fear and anxiety. By analyzing gait, we treat specific functional limitations, not labels. Precision interventions replace guesswork. We can measure step length, cadence, stance time, and gait speed, objective progress. Data empowers patients with tangible proof. It elevates documentation and communication. Evidence-based practice for better outcomes. You don't need a motion capture lab. Your best tools are your eyes, your ears, and your brain. Step 1. The observational overview. Let them walk naturally. Minimal instructions. Watch from the front, the back, and the side. Record on a smartphone for slow-mo review. Listen for rhythm, steady or asymmetrical. It hints at step length and stance symmetry. Scan posture and balance. Is there sway, forward, backward lean, reduced arm swing? Big picture first, details next. Break it down. Stance, heel strike to toe off. Heel or flat foot landing. Knee stable or hyperextending. Strong push-off? Track one leg through several cycles to spot consistency. Then swing. Toe clearance, knee lift, straight path or circumduction. Connect findings across views. With neurological patients, patterns repeat. Recognizing common deviations is the first step to correcting them. Foot drop, circumduction, Trendelenburg. Foot drop is dorsiflexor weakness, risk of toe drag, with compensations like hip hike or circumduction. Shortened stance on the affected side, rhythm uneven and hurried, often with lateral trunk lean. Trendelenburg shows stance leg abductor weakness, pelvis drops on the swing side. Parkinsons, festination, stooped posture, reduced arm swing, and freezing, especially at starts in doorways. Spasticity can cause scissoring and equinovarus, forcing unstable lateral foot contact. Intervene at the nervous system, task-specific practice, external cues, manual facilitation, timing drills, FES when indicated. Use visual tape, steady beats, and light tactile cues to build symmetrical, efficient patterns. Meet John, recovering from a right-sided stroke. You notice right leg circumduction, decreased right arm swing, and slightly shortened stance time. He's compensating for weak hip flexors and foot drop. Start with task-specific practice. Step over small, soft obstacles. Cue knee lift, then toe lift for clearance. Constrain the path to discourage the outward swing and encourage knee flexion. Use a metronome and verbal cues. Left foot, right arm, right foot, left arm. Add tactile prompts to reintegrate arm swing. Progress with small hurdles, increase tempo, and add dual tasks to build robust, transferable skills. Our patient's gait tells a story. Gait analysis helps us read it precisely. It's the difference between generic plans and patient-centered change. It elevates us from technician to clinical detective. Recap. Start with observation from multiple angles. Break the gait cycle into stance and swing. Pinpoint when and where deviations occur. Foot drop, circumduction, Trendelenburg. Use external cues, your hands, task-specific and dual-task training to guide efficient movement. Call to action. Take 5 extra minutes. Record, listen for rhythm, spot one asymmetry, try one targeted intervention. You'll be amazed at what you uncover and what changes when walking changes. Keep learning, stay curious, and refine your eye. You can unlock better outcomes, one step at a time.